So hello everyone. Now today we are again with another session of live session with the very eminent physiotherapist with us, Dr. Shhalini Grover. She is a PhD in physiotherapy. She is a manual therapist and associate professor at and she will be taking at on the topic anatomical trains lecture today. She has done series of workshops on isokinetic, dynamometry, wheelchair skills training, basics and advanced. So many of she has a very caliber in physiotherapy profession and a lot of certifications. She has done a lot of certification in the chiropractic techniques, anatomy train, and all that concepts. So join me to welcome Dr. Shhalini Grover here, and she'll be delivering and enlightening us with the anatomy trains. So over to you, ma'am, please.
Hello, everyone. Thank you so much. Thank you, Dr. Dharam Pandey and Dr. Harpreet. Thank you for inviting me on this platform. So now we're starting with our topic. Today's topic is anatomical trains. So what are basically anatomical trains? Anatomical trains in our body, in our anatomical body. So there are various lines which are made up of fascia muscles. So if they are connected to each other, so any of faulty dysfunction of one muscle, one fascia is attached to the other fascia. So we have to read first the anatomy of these trains before landing into the dysfunctions. So what are the anatomical trains? These are the group of myofascial meridians that run through the entire body, starting from scalp to your cervical spine, to your thoracic, then your pelvis, your lower leg, and up to your great toe. So it is a very unique whole body connection we have. It also gives us the concept of soft tissue therapy, thereby treating one area, because in soft tissue therapy, we treat only the dysfunction soft tissue, altered mechanics of the soft tissue. So we treat one area along with that within one of these fascial trains. It is influencing not locally, but globally the entire chain. So if we treat, suppose, if we treat the plantar fascia of the body, of the foot, then the hamstring will also release. If there is a bending problem or somebody will not able to bend fully, and we think of hamstring stretching, and suppose after that also there is no response, and we stretch the fascia, then also we can have the increased range. So we have basically 5 trains according to Mayers. So it has divided into a superficial back line. So it consists of, start from plantar fascia, top to the gastrocnemius, hamstring, sacrotuberous ligament, and thoracolumbar fascia, erector spinae, nuchal ligament, and scalp fascia. So it is in the back of your body. So this will stretch when you do all the bending activity. So when you forward bend, then the whole fascia of your superficial back line will stretch. And if you do cervical flexion along with forward bending, this will stretch the scalp fascia also. So if I want to check my whole thing, whole fascia, I have to make the person forward bend fully, right? So next is superficial front line. So it starts from anterior compartment of periosteum of tibia, that is shin of tibia, jahan pe aata hai, rectus femoris up, then rectus abdominis in the center, and pectoralis sternalis fascia, sternum ke aage, then it goes up to the neck, sternocleidomastoid muscle. So it is a front line of the fascia. So this will extend when we do backward bending. So if we do backward extension of the spine, the whole front line fascia would stretch. Next, we have a lateral line. This includes the side of the peroneal muscles of the leg, IT band, TFL, glutes maximus, external oblique, internal oblique, quadratus lumborum with the deep fibers, internal, external, intercostalis, spleninis muscles, cervices, iliocostalis, up to the sternocleidomastoid and scalene triangle, all the scalene muscles. So it is a lateral line of the body. So when we do side of the stretching, side of the bending, then the whole lateral line would get stretched. So if there is problem in any of the muscle, this lateral functional line movement would be affected. Any of the muscle. We have to find out through diagnosis which muscle is actually at cause. So if we find out that muscle, then it's okay. We treat the local area, your functional line would be improved. But if we don't find that area, where is the fault? Suppose the fault is an IT band or fault is in glutes maximus, and we are not able to find out the area, then what you do is a doing of that functional, all the activity to this lateral line. So any of the stretch would affect that gluteus maximus where the fault is lying. Okay. Next is spiral line. So in this spiral line, we have lot of muscles because it is starting from anterior side of the body, crossing the body, and then back of the body also. So it starts from, we think of in the opposite side, spleninis capitis in the neck muscle, rhomboids of the opposite side crossing to the upper back, serratus anterior muscle, external internal oblique, next is TFL side पे चले आती है, फिर IT band, next front of this anterior tibialis, peroneus longus, फिर back of the thigh में जाके bicep femoris, sacrotuberous, sacral fascia and erector spinae. So it covers the anterior part and then posterior part. So it goes spirally into the both lines. Next is deep front line. So deep front line is, it is starting from posterior tibialis, interosseous membrane, knee capsule, adductor hiatus, adductor muscles, intermuscular septum of this femoral triangle up to the hip flexors, psoas muscle, anterior longitudinal ligament of the spine, then diaphragm, then the pericardium, mediastinum, parietal pleura, facial prevertebralis and scalene muscle. So it is a very deep muscle which stretch in a posterior bending position, or we do all the functional activity which require more of bending back. They all are interconnected, the superficial front line and the deep front line. Next, we have arms line separately because leg lines are along with the anatomical body, central body. And now the appendicular. Appendicular means back of your arm lines. So first track goes from trapezius, then deltoid, the lateral intermuscular septum, the common extensor tendon, and second track goes from rhomboids. So it includes all the rhomboids muscle, infraspinatus, triceps, periosteum of ulna, and small finger. So these are two tracks of extending in the arm area. Third track is a stabilization, which connects the track from central body to the appendicular body, right? So arm ko connect karne ke liye we have a latissimus dorsi, thoracolumbar fascia, sacral fascia, glutes maximus, vastus lateralis. So these are the stabilization track on one side which stabilize the first and second track of the arm. So if we want to stretch this arm tracks, we have to focus on that. These should be stabilized. If that core, suppose these are basically the core muscles also. So this would be stabilized. We have good stretch of that fascia, these arms line. Next is front of this arm lines. That was the back of arm lines. It starts from latissimus dorsi, teres major, pectoralis major, medial intermuscular septum, medial epicondyle, and palmar side of hand and finger. Second track starts from pectoralis minor, bicep short head, coracobrachialis, radius and flexor compartment, thumb. So one is for the fingers and one is for the thumb. And it also have a stabilization tract of the central body. That is pectoralis major, external oblique, this side adductor longus, gracilis, pes inferens, and tibial periosteum. So these are the body facial line which is connected with the arm line. So we have a anatomical train concept and we have a functional movement assessment concept. So we have to do an assessment with this and we treat the facial lines. So assessment and then diagnosis with this and then treatment through the facial lines. So we have to collaborate these two concepts. So basically this selective functional movement assessment, it has a lot of tests, but top tests are 7 top tests, which evaluate the basic fundamental pattern that display an individual ability to either do it functionally, do it non-painfully, do it this way. So we have to complete the movement with, if the person can do the movement perfectly without pain, that is functional and non-painful, FN. That the person can complete the movement but have pain, that is functional and painful. He can bend the body, function can be complete but with pain. So that is second. Third is unable to complete the movement without pain. Pain is not there but resistance of the tissue is there, which is not allow the person to complete the movement. That is dysfunctional and non-painful, DN. Next is unable to complete the movement with pain, dysfunctional bhi hai and painful bhi hai. So patient always come with in this category. Cannot do the movement and pain is also there. So in this category we have all the categories. तो हम चले गए. ये लोग तो तब आते हैं जब पेन इतना ज्यादा बढ़ जाता है या डिस्फंक्शन पूरा आ जाता है, like frozen shoulder. So frozen shoulder में dysfunction of the joint is there and pain is also there. So we have to mobilize the joint. You are mobilizing the joint, but along with, if you are doing that functional movement of that shoulder complex, then the result would be better. So focus these functional lines in any of the dysfunction. So these 7 top tier tests are cervical spine pattern. So we have to see first the cervical spine pattern. You generally see all the diagnosis, all the patterns during your examination. So first we ask the patient to flexion, touch the chin with the chest. So we see the movement is complete or not. Is able to touch the chin with the sternum or not. Is a non-uniform spine curve. So we have to see what is the curve of bending that thing. Or he felt excessive effort of doing that thing. So we'll see how he's doing the behavior of pattern, complete the range of motion, and it's the uniformity of the system. There is a instability kind of thing. Right? Next is a upper extremity. Sorry, इसमें cervical extension भी. So extension may look back into the ceiling. So just we see the patient can do the full cervical extension parallel to your this thing, or non-uniform, or there is a excessive effort or lack of movement. So whatever you see. Yeah. Next is a rotation with flexion. We ask the patient to do this chin to clavicle. So clavicle को touch करने के लिए. So this is rotation with flexion. So we check whether his chin is touching to the clavicle or the same, the behavior of pattern or the spine stretch. Sometimes the patient do that and hiking of shoulder is there. So we see what trick movements are happening along with that. So pattern is changed because this is a normal pattern. Now the patient is doing with this. Okay. So pattern is changed. So we have to see our shoulder arm pattern is also changed. So we have to see the whole pattern till the finger. Okay. Next is a upper extremity pattern. So we'll see the abduction with external rotation. So we're reaching the arm around the head, attempt to touch the superior angle of opposite scapula. So we see this, if in this position, So we see the arm tract, latissimus dorsi is also working. All the arm tract is working. The extensor is working, and all the fingers they are also. The whole functional line is working or not, right? Same with the opposite. See, without movement of your cervical spine. Then next is adduction with internal rotation. We see the patient is able to touch the inferior angle of scapula. So if the patient is able to touch the inferior angle, then the pattern is complete. So if there is no bending while touching the patient will do and like this. So thoracic flexion is also there. So we see the functional line is the superficial front line is shortened and back line is lengthened. So while lengthening the fascia, you can complete the movement. Okay? Just observe, visualize the pattern of doing the movement. So if there is a, we'll check the right and left side, we can compare and we can just visualize there is a difference. So which line is affecting? So focus not only that movement, focus on the whole line. Okay. Next is multi-segmental flexion. Multi-segmental is reach down and touch your toes. So when you are doing forward bendings like this, right? When you're doing this, we just see what kind of this movement is happening. So patient is excessively doing backward movement of this, then forward, or stooping first and then bending forward. So we see all the line reach down and touch the toes, or what is the difference? So this is multi-segmental. You are seeing the hip, pelvis, lower spine, thoracic, and then cervical is also involved in this. So during the multi-segmental flexion, we see cervical also. Multi-segmental extension. So reach overhead and extend your back as far as possible. So in this we see when we are doing backward, our ASIS is, so when we are doing backward, see our ASIS is shifting forward your toes. It is not fixed and you are bending, so you are bending from upper line. Your lower line is fixed. So ASIS should come forward. Okay. Next is multi-segmental rotation. So in this, rotate your body as far as you rotate. We can break this rotation also. We can break in rotation like this. First we see in sitting. So we see the sitting rotation. Then we can see if this thing in standing way. The patient is doing rotation in standing. So we have to see breakout or we have to see a whole movement together. Okay. So rotate your body as far as you can reach each side, keeping your feet flat. So there should not be increase of arch and your foot on the foot. You are increasing your more weight on your lateral border, then you are moving in this direction. See these variations from, because if your fascia of the foot, plantar fascia is also tight, this will move the limb into lateral rotation. When there is a lateral rotation of the limb, gluteus maximus would work more because there is external rotation of the leg. So max will work more and max will do the rotation, not your upper body. So you're not able to check the facial line correctly. Next test is single leg stance. So in this, we ask the patient to stand on one leg with other leg at least 90 degree or hip flexion. So in this position, we do like this. We ask the patient to do this, or we ask the patient to do this backward. So what is the variation he can able to perform backward of fist or 90 degree of hip? So we'll just check what is the balance and the functional line of one leg is working. So that is, we can have for the 10 seconds at least. Next is overhead deep squat and lower arm deep squat. Both is okay. So overhead, maybe ask the patient to do overhead and do the squats. You will see the arm is coming down along with squat or it is remain there and doing the squat. Sometimes we do lower arm squats. So when we do lower arm squats, then also we'll see there is arm is stationary and doing the squat, or otherwise we are taking the help of upper body and doing the lower body squat. So I'll explain later also. So this is multi-segmental flexion. So toe touch. In this, the back of this segmental superficial back line is lengthened, right? From plantar fascia of the bottom of the foot to the scalp. So if the movement pattern is dysfunctional, visual observation of the posture or palpation of the structure, you see all the palpation where the patient complains of pain. The patient complains while bending forward, I feel pain here. Sometimes patients say, I feel pain at the back of this lower back, or the patient feels back of my knee. So where the structure is faulty or he is not able to complete the movement, where is the fault line. So you can easily diagnose in the line where is the dysfunction. So we treat that locally. It's easy to find out the main areas of restriction along this line. Example, the tight or toned gastrocnemius, lumbar erector muscles, suboccipital muscles are the common for the upper and lower cross syndrome. So in this, the patient, we do this facial line movement, so we able to diagnose which area is at fault. Next is multi-segmental extension. So it influences two major lines, that is front, superficial front and deep front lines. So by assessing the movement, first we choose to further evaluate or treat components of these lines. So which is the effect component? It's a rectus femoris or it's a rectus abdominis. So which area is affected? So by treating the diaphragm, suppose diaphragm is also there in this line, it's a deep structure, deep front line structure. So treating the diaphragm and working on improving the breathing can rapidly increase the tone of hip flexors muscle and quadriceps also. So we are working on diaphragm muscle, good breathing, and they are increase the extension is also. So sometimes patient cannot, patient is unable to tell you where is the pain, but I cannot perform the movement. So if the patient is not able to perform the movement, you have to see which muscle is at fault, or there is some, we just alter the breathing pattern, we just stretch one of the this thing and then do the movement. So if you are stretching and simultaneously you are retesting, then you can able to judge you are actually at the right path. The multi-segmental rotation, so it influences many lines. The lateral lines also, because we are doing rotation, so lateral lines and the spiral line of the body. So all of the line discussed above can impact this movement, that is lateral or spiral line. First determine which rotation is limited, left or right, and then consider action of these lines where the muscle is at fault. So if I rotate to the left, which muscle are internally rotating and which are externally rotating? So some muscles are of this side, oblique muscle are externally rotating and these muscles are internally rotating. So where is the fault lies, and treat one or two areas where the major restrictions are there. There was a flexion with rotation range of motion test from cervical spine pattern can also influence this line. So we see this along with the chin to the clavicle. So along with this, if this is affected, we cannot move this way. If my cervical, this muscles are affected, suppose sometimes the patient has a SCM constriction, or sometimes there is a facet locking also, and all the paraspinal muscles of cervical spine is restricted. So this rotation will also not possible because of the cervical. So we have to see which component is affecting your movement. Okay. So in upper extremity pattern, so there is abduction and external rotation, and adduction and internal rotation. So treat the front of the arms line and the back of the arm lines. So all of the muscles in the arm line, especially the stabilizing tracts, have an integral connection with other line of the body. So the treatment of these structures would be comprehensive. So if we are treating, suppose a frozen shoulder or any shoulder dysfunction, so we are doing a shoulder movement, shoulder range of motion karate, then we have to look for the stabilization tract. Stabilization tract are latissimus dorsi, teres major. So if we are doing that thing, so all four positions, or we do side bending of this will also come in this if we are taking this side line, lateral line in this frozen shoulder. So stabilizing pattern also have effect on the upper extremity. Next is the single leg stance or overhead squat pattern. They are complex and require a higher level of both the stability and balance, mobility. These patterns require a communication from all lines simultaneously, because sometimes we are squatting to bend hoke karte hain, so back line would be this thing, but we are simultaneously doing overhead arm, front would be stretched. So it involves all these patterns. So prior considering to these two patterns, improve possibility of the previous pattern. So we do all the tests for forward bending, then backward bending front, then superficial front, and superficial back, deep back, arm lines. Then at last we do all this overhead squat pattern and leg stance pattern. So this is just one concept. There are many ways of assessing the individual prior to treating the soft tissue. So treat a few structure, retest, then treat few more, always keeping in mind that we must think about the lines that are being asked to lengthen and the lines that are being asked to shorten. So, and interplay between them. So which are in our yoga postures, various lines are there, various which are going to be stretched. So I'll just demonstrate you some of the pattern where we can have functional activities where we see this, which line is to be going to stretch or which line is going to be shortened. So if we do a mountain pose, so we are doing like this. So in this position, mountain pose, so in this position, you are actually working on your back superficial and back and cervical scan. So whole of the pattern is affecting and I'm using the arm line also. Right? Now I'm doing this way and then come to this way. So all your movement are affected by your line pattern. So if we are working on one line patterns like a Surya Namaskar, this is basically working on your back lines and front lines along with your arm. So that is also very good. That's why it's called very good exercise for all the functional lines. It affects the back lines also, front lines also, and arm lines also. So you have to concentrate on these lines before diagnosing the treatment or before assessing the patients. You are assessing the local thing and simultaneously assess the global thing also, so that you can decide their treatment pattern, functional pattern, so which is affected, and now we can train them functionally. You are treating your any of the area, and simultaneously if you are giving that functional training to the dysfunction, so that is an add-on effect. So I think that is very good. Nowadays we are working on whole muscle, not that locally. We have to concentrate on global muscle. Thank you.
Yeah, thank you so much, ma'am. It was a very elaborate and extensive explanation about the anatomical trains and how it can impact, or how one region of the body can impact function at some other region. So just a few questions, like, or you can say them as doubts, that when would you choose this as to be your primary assessment or treatment method? Like, is there anything that you say that this is the place I would go by anatomical trains before choosing anything else?
Okay. So if the patient come to you and the complaint of the patient is, I cannot bend forward fully, if I'm doing forward bending or any of the activity, I am feeling a pain, vague pain. Patient is not localizing the pain, And there is no mechanism of injury. If you ask the history, then there is no mechanism of injury which is directly related to the local dysfunction.
Right.
The patient says, I'm sitting for long hours, then I feel pain in my back, and then when I lie down prone, the pain will be reduced. So I'll see which line is affecting. Suppose his posture is not correct in the sitting posture, and after that also, if he's sleeping in a bad posture, the line would not correct. And I'll see he require more of that functional training rather than the local release of that. So if I do completely functional training nowadays, actually we are more on focusing on the exercises part. So we ask the patient to do that functional training, give them all the exercises which is affecting that line, and then see the result. I think that would be
Okay. Just one more thing, like when would you say that you would not recommend anatomical trains in this condition or at this place that I would not
seriously
like to...
says nowadays I am recommending every dysfunctions later on also when the dysfunction is treated with mobilization or my work of manual therapy is complete. I put all the patients into functional training usually because it affects later on in their life. The muscle would strengthen and their stabilizing function will also would be there. If we correct one thing and then patient would come after 6 months also, then I have a pain, now I have pain there. So I realize that the pain can travel from one plane, one line to other. So if I, usually nowadays I treat more of the patients with manual therapy, then उनके बाद बेशक कोई भी dysfunction हो, functional training में डालते हैं, whether it's a disc pain also.
Okay. And just finally, just to clarify my own personal doubt, like if there is no problem as such in the patient, would you recommend any of these movements because they very closely relate to yoga? And yoga is sometimes used without any dysfunction as a normal fitness regime or a fitness protocol, you say. So can this be used in a daily fitness program as an exercise? Okay.
Yes, yes. In daily fitness program, what I recommend is your core muscle should be worked daily, along with your upper body movement and along with your lower body. Not like that today is our leg day. So we'll do all the squats.
Right.
So if you are doing squats, you are basically doing L5, S1 dysfunction.
Right.
But if you are doing squats in different position, if I'm doing standing squats, then if I'm doing in a plank position, then the movement of your leg. This is also the movement of your knee, but I'm doing plank in this. Suppose one movement I'll demonstrate.
Right.
So I'm doing, there are various plank variations. So if I'm doing this plank variation, right? So now I'm doing this movement. So this is movement of So this movement is of my knee point. So knee movement हो रही है, it is strengthening my quadriceps, but basically with the core, with the pelvis stabilization. So I am not focusing on all the muscles. I am focusing on all the muscles simultaneously. But the patient will get to know my more effect on the quadriceps muscle. So your voice is not there. You're muted.
Yeah, I feel that it is a global way of exercising, but still you can localize to some pathology in some areas.
Yes,
so,
yes.
So I think it serves both the purpose of the treatment.
Yes.
And I think it is something that every movement expert should know, and something as a tool that everybody should have with him. So.
It is very effective for sports person. This should be there. The program, exercise program, should be of strength and conditioning. So conditioning part comes in this functional flexibility, not only the strength.
Yeah. So thank you, and we expect that the information you have shared would help many in utilizing this concept. Dr. Dharan, anything?
Yeah, no, it is a very well explained, Dr. Shhalini, and. So whatever the question I had in my mind, Dr. Harpreet has already addressed that. So with this note, thank you so much for accepting our invitation to come to Rehabilitation Science Group, and you have shared wonderful knowledge, and I'm sure that this is going to help the audience understand the concept of anatomy train and possible exercises, functional training, what you have experienced. So thank you again. Thank you so much.
Thank you, sir.
ma'am.
Thank you so much for inviting me, and thank you. I hope I'll be there again in future with
Sure,
you
sure,
people.
sure. We will.
I'm happy so much. I'm
thank
glad.
you, ma'am. Thank you, ma'am.
Thank you so much.